All right, I think we're going to get started on our afternoon session. The first talk for the afternoon session is a follow-up on Joel's talk on the learning curve. One of my missions is to make a department a completely HoLEP department. That is, no more TERPs. And to do so, yeah, I'm working on that next. To do so, my goal is to have all of our primary BPH surgeons be facile at doing HoLEPs. And to that point, we've trained a number of our faculty now. So I invited Adam, Miriam, and Neil to come talk about their experience in learning it, and especially about like barriers, things that we could do differently to speak about that. Okay?
All right, howdy. I have just a couple slides. My name is Adam Walker. I'm at the West Shore Urology practice, which is out in Muskegon, not too far from Fremont. Yep, real close. And I don't have any disclosures. I can go to the next slide. Let's see here. There we go. All right. So what John says and what he thinks, I think, are probably different as he proctored me. We kind of joked that he probably after the first few cases could have just made a recording of him saying the same thing, and it would have been very effective. Pull back, look up, look distal. We heard that in the kind of talking about training residents. Blanch the capsule, push on it, and so he was remarkably patient as he proctored me, and I saw him reach for the morcelator several times, and I kind of know what it was. Now I know why that was. So as I kind of reflect on learning this procedure, the first thing I'd say, and this is a picture of Muskegon on the lake shore, and it's a relatively small community. There's nobody along the lake shore between Traverse City and I don't know how far south that's offering this procedure to patients. There's a couple folks in Grand Rapids. But there's a lot of patients who, have had 2, 3, 4 TERPs or green lights or whatever, and they just haven't had access to this. And in a small community, there's a lot of resistance towards going to a bigger academic center, or even traveling to the big metropolis of Grand Rapids for care. And so, in terms of this procedure really reaching that critical mass, it has to go out beyond the academic centers. It really has to get in the hands of community urologists like myself. And it really is a service to the community. There's people that have just not had any options that have been, I just saw a guy back this week that he had lived with the catheter for a year because he had a big gland, and just they need this kind of technology and this procedure. I would really emphasize the importance of a proctor, if at all possible. You guys have learned it on your own without much proctoring. I think it drastically speeds up the learning curve if you have somebody that can watch you, look over your shoulder, be there real time with you as you do these procedures. I saw a pretty well-known endourologist recently who was doing a HoLEP as part of another course that I was at, and he said, "Yeah, I'm about on case 47 or 50 or something like that," and never had a proctor, and it was rough. Like, we didn't really ever see surgical capsule, and I think it just speaks to the difficulty of learning this without somebody to be kind of at your elbow for at least a bit. We've already talked about the Goldilocks principle: not too big, not too small, just right. That 60 to 90 gram gland is ideal for starting, and that's certainly, I found that to be the case. I'm still pretty early on the learning curve. I'm almost at, I think, 50 cases at this point, and that's still generally what I'm doing. I've done a couple smaller ones and some bigger than that, but generally in these first few cases, it's been that size. And The one thing that I'd emphasize is learning after residency actually has some advantages. You're much better. You have a lot more experience endoscopically. You know how to manipulate a scope. You've done a lot of TUR procedures. You're very facile, endoscopically, and I think that probably does speed the learning a little bit. It still can be a challenge, but it certainly can be done after residency without a fellowship.
Cool. All right, I'm Neil Pugashetti. I'm one of the urologists. I work mainly in Chelsea, which is about 15, 20 minutes west of here. So this will be my foray into HoLEP. So a little bit of how I got here. I'm from California. I did residency at UC Davis. Some of you may know Noah Canvasser, who trained here with Casey. And he was sort of learning HoLEP, but also teaching it, kind of reacquainting himself with it while I was in residency. So I'd like to say I did 10 to 15 cases in residency, but I mean, in reality, I don't think I did a whole lot. Did maybe various parts of the case, a little bit of this, a little bit of that, but probably not a ton. And then similar to Miriam, I took sort of 9 days, and I really used those days where I didn't do any of my own clinical activity. I went with John Way and did probably in total 25 cases or so, where initially I started by doing nothing and stepwise kind of increased that responsibility. And then, after that kind of 3-4 month period, he told me I need to just book my own cases, and he made me do it on my own, which I was like absolutely petrified of, by the way. The night before, I could not sleep. But he came, and he didn't really do a whole lot, except for I think the 3rd case, he was like, "You seem tired. I will do the 2nd lobe." And and then since then, I did 20 of my own in the first 6 months, and now it's up to 120 I counted the other day in about a year and a half. So it's been going well. It's still very difficult. So this is sort of my learning curve. I think I knew nothing in residency, and when I did a little bit of enucleation, I was like, "Oh, I'm so good." Confidence was high, and then I started doing this with John, and I was like, I really know how to do nothing. And then slowly, it increased. So 50 cases, I was like, I can get through this. I will make it home. And now I'm probably where that star is, where confidence is a little bit higher, competence a little bit higher, but I'm not quite there with all the other folks in the room who I'd consider kind of gurus or masters at this point. So similarly, kind of evolution of my confidence in this case. Initially, just wanted to get through, wanted to get home. Staying in the right plane, a million different planes, to finally trying for a little more finesse, trying to be a little more efficient with the enucleation, actually getting the most tissue out that I could conceivably get without making enormous capsular perforations all over the place, and doing these little things that, after watching a million YouTube videos, trying to avoid the contractures and a lot of these things we've talked about. To now, I'm trying to do this, some form of early apical release, or some form of trying to limit things like stress incontinence. And then just like Miriam and others have talked about, increasing case volume. 1 a day was enough. My cortisol level couldn't handle more. To 2, and then 3, and I'm at 3. I really can't handle much more than that, or I get exhausted emotionally. And similarly with the prostate size, the Goldilocks thing, initially I was like, I will not do a gland above 100, and then it was 150, 200, or whatever. Now it's 250, and that's my firm upper limit for now. So I set expectations very low. So this is sort of what I did, and I feel like it was successful in terms of other, for someone else to model how to do this without a fellowship necessarily. I set the expectations super low for patients. I told them they're going to leak forever. You'll be lucky. I mean, I'm just being honest. You'll be lucky if you are continent by 3 to 6 months, and no one cared. And those are the patients I really booked, frankly. And no, it wasn't true. They were continent, and it was fine. But I also didn't promise they were going to get their catheter out in the PACU, and go home that day. I kept the expectations low without being ridiculous, but and then avoiding, reoperations, tried not to do the post green light, post Urolift green light, anticoagulated that can't come off, and really frail patients. Another one was the high maintenance patients. I got a lot of referrals from, Ann Arbor professors. This is probably not the person I should do, so I sent those to John and Casey, which I thought was appropriate. And I said, no, I'm not going to treat your renal stone at the same time. So I tried to limit as much outside variability as possible, 60 to 100 grams, like we've kind of talked about. Even in spite of that, I've had a fair share of complications, which are improving over time. We all will get complications, and I'll continue to get them. But, some of the scary stuff has happened. I think the one, aside from the typical ones here, like thromboembolic events and infections and hematuria that we all see. I had one issue with the finicky morcelator where the actual morcelator device wasn't working. And this is just myself talking through that complication a little bit, but the morcelator stopped having outflow. It was all inflow, and to the point of, when the staff is not totally on board with what you're doing or having a new staff member in the room, that happened, all the bad things happened, and it was sort of like a pressure injury where, it made a little hole in the bladder. We had to X-lap and repair it. Ultimately, he did fine, but these things happen, and I think luckily they are few and far between in my experience. So couldn't do it without mentorship. This is a real life photo of John teaching me something before a HoLEP, and then Casey swimming across Chelsea to come help me when the water main broke. It's been nice. John operates at the U, but he really showed me how to do the procedure, and Casey operates at Chelsea frequently in the next room, so I've called him in a couple times, really for moral support. He just looks at the screen and says, I don't understand, this isn't bloody, it looks fine. He leaves, I'm like, well, I guess it does look fine, and then I can finish the case. So it is good mentorship, but it is, in all seriousness, it really is just a good luck pat on the back and he leaves, but it's enough. So anyway, thank you, that's my experience.
Thank you guys for doing that. I'm starting to get a complex because I realize everyone that I teach HoLEP all say the same thing, that it's very stressful and they go home and they need to crash after operating with me. I'm gonna have to change what I do. So our next speaker is Dr. Lori Lerner. She is an associate professor at Boston University. She has accomplished many things. She's currently the chief of urology at the Boston VA. She's associate chief of the surgical service. She's done many things for BPH, written a lot on HoLEP, and she did her fellowship training with Dr. Gilling back around 2000. And in fact, Lori, I met Lori before I met Peter. Lori's the first person I ever met who did HoLEP. I didn't even know what it was when I met Lori many years ago doing BPH panel work. So I invited Lori to come and give us a talk, and she's going to talk about HoLEPs and continence.
So my mentor, pat on the back, during fellowship, and it wasn't Peter, it was Mark Fraundorfer, and I was doing an open nephrectomy, and I just felt like I wasn't progressing, and Mark was in the T room. And so I had them go get him, and he came in, took one look, took a knife, extended the incision by about that much, and walked out. And later, when I talked to him about it, he says, what is it with you? All of you have to operate through this little tiny incision. And it was really interesting. The second that he gave me more exposure just by opening it up, I'm like, oh, I know exactly where I am. Everything is fine. I now see this, I see that. Anyways, it was really funny. Same sort of thing. Didn't say a word, scrubbed, took the knife, made it bigger, and walked out. And that was my pat on the back. So the incontinence thing is, I say that it's near and dear to my heart with a sort of weird phrase around that. So when I came from my fellowship and started doing HoLEP, this was one of the things that we saw, and there weren't that many of us, and we didn't really want to talk about it. I looked at my own data, which I'll get into in a minute, and couldn't get it published. And there weren't that many people who could evaluate or review peer review articles for HoLEP at that time. It was just a very small group of people. And each time it would get rejected, I knew that it was being sent to the same friggin' people, right? Who didn't want to see it published. And so finally, one of them, Mustafa El-Halali, called me after like my third submission and said, look, here's the thing. The thing is that what you're seeing is very honest data, but this was in the middle of the laser scope and everything is so much better if it's green light and whatever. You just can't have this be the focus of the paper. And so I had to rework it and really go back and think about it. And it took me a couple of years to really sort of redo all this data. In the meantime, though, what I felt very good about is that it correlated with Jim and others looking at that same time. So we all sort of came out at the same time looking at incontinence. And so I consider myself the person that really sort of propagated the idea that we actually do talk about it. So when I was when I was on BPH guidelines, and then became the third chair of BPH guidelines, I had zero conflicts. I divulged myself of absolutely everything that had to do anything with industry. Since then, I've gone back and done a little bit more. None of it is relevant to this talk. Most of what I do now is just either consulting work for things like space or regulatory work like what John was talking about. I do have a big interest in UTIs as well, and I'm a clinical trial site for a UTI vaccine. So those are kind of where I'm at. So nothing is really relevant to this particular presentation. So what is the occurrence of stress incontinence after HoLEP? And, like I said, I'm glad that we at least talk about it, because I will still say, and this was probably one of my biggest complaints about aquablation, which I'll flat out say it, is that people have got to be honest about we can't do right by patients and we can't do right by our colleagues and other people when we just can't be honest. There just has to be no ego. I say that knowing that I have ego, right? And I have a fragile ego at times about certain things. But now I'm been doing this long enough that I care less and less about it. But especially for those of you early on, it's uncomfortable to sort of look at your failings or to be honest about them and not want to explain them away by something else, and I get that, and I want to do that too all the time. And most of the time it is something else, and it actually isn't you. So I don't think we need to take responsibility for patient factors that are patient factors. But I do think you need to take responsibility for saying, am I considering those patient factors into my decision making? So maybe this patient had this outcome because of these other factors. That's fine. You don't have to own that. But you do need to own, maybe, should you have done a modification or should there have been another procedure, right? And I think that that's the kind of granularity we need to get into with BPH. So, this is what's really interesting, right? So what is the occurrence of post-op stress incontinence? So, and I remember talking about it when we coined the word transient, because we do think it was temporary. Temporary was the word that people used initially, and we sort of morphed into transient, which I preferred. I know some people don't like that term either, but the ranges are up to 44%. It's because it's one person presenting their data, one institution or maybe a couple of people. We don't have a way to look at this across all people, right? Who are doing enucleation and then sort of codify that into gland size and all that kind of stuff. It'd be nice if we did. Goliath was that group of people that did PVP who all subscribed to the Goliath trial, and they brought in all their data, and so they were able to look at it as a big sort of group. And that's what the Holmium Users Group is attempts to do as well, is to look at all of this in aggregate. But it does make it more challenging. And I think that, permanent incontinence risk is low, but I think you do need to be honest. So what do I tell my patients? I tell them there's a 50% chance. I just go straight. Right off the bat, I don't think in my hands there's a 50% chance. In fact, I know there's not, but that's just what I say. And because I need it to not be a surprise, right? So I need them to understand that this is a possibility. And the definitions of stress urinary incontinence also really vary. So when we did our project, I said, anybody who feels they need to wear a pad. In my mind, that is a change from how they were pre-op. that got a lot of criticism because at that point in time, the radical prostatectomy data very clearly said you had to be wearing at least one pad. You had to at least have one pad wet. And they didn't count security pads. So everyone was using that. Okay, who's using more than one pad? If you've got one pad, it doesn't count. And I was like, but it does count. We are a lifestyle operation. This is another thing that, so God, like I'm going to be on my soapbox today. Sorry about that. With the residents, I'll say trauma surgeons and cancer surgeons get a pass for a lot of things because they're doing it in the name of cancer and they're doing it in the name of trauma. When you are an elective surgeon, you are a lifestyle surgeon, you do not get that pass. And I have this conversation, and this is my biggest bugaboo about conduit. So don't even get me going with the oncologists and whether or not they do a good job on the conduit, on the stoma. Because this is their life. This is their lifestyle. You do not get that same pass. So that is why I think we have to be very honest and be willing to modify, because they're coming to you for a lifestyle choice. Do not make their lifestyle worse. So I think anybody who feels that they can't go out of the house without wearing a pad, that is a lifestyle choice. So I look at my own data in that way. So what is our paper that we did? So it finally came out, and I can tell you I started trying to in 2007. So it took me that long to rework this in a way that felt acceptable to people. And it largely came from when I first came back from fellowship. And somebody out here mentioned this. So when I came back from fellowship, we didn't have a laser like where I came. I left New Zealand and I came to Dartmouth. We didn't have a high power holmium laser. So I did nothing for a while until we could work out a rental agreement. And then I got married, and then I got pregnant, and then I was out on maternity leave, and then I came and that lost momentum. So there were all these different things that happened that really got into my learning curve, right? And I was dabbling, and I think we've all heard this word. You cannot dabble when you're learning enucleation. You got to load the cases. You got to front load the cases. Whenever I go, and I don't hardly do this at all anymore, but in the past, when I would go like down to South America or whatever, I'd be there for 2 days and do cases, and there'd be like 12 urologists, and they'd each want to do one. And I'm like, okay, well, I don't think that's going to work for me to sit here and just teach each of you one case, like get through this. I think you guys have to all commit to like one person getting really good at it and then proctoring others as you went along. So I then looked at this and said, okay, fine, we're going to look at this totally related to learning curve and to frequency of cases, which makes sense, right? So, despite getting rejected over and over and over again, it did turn into a much stronger and a much more compelling story that is easier to understand in the context of learning curve. So if you look at this, and this is, again, what I did. So in my first 2 years, I did 14 cases. I mean, you can't expect that things are going to go well. That is definitely dabbling. And then I got the laser, no more maternity leave, got divorced, so there were no more kids, and just continued to throw myself into work. And then I did more and more, and my transient incontinence rates went down. And that's what's really important to see. So even though these numbers are low, and those of you who just talked, are doing higher numbers than this, but it was really hard to get somebody to be willing to do an enucleation back then. Like I said, there were 3 of us in the United States who were doing it that were not in the fellowship program, so it was me, Akil, and Jim initially, and then Mitch started in fellowship, and we started doing more. And so, this was this sort of thing. They're not going to, even my own partners didn't really want to send patients to me. But the point being is that the more you do it and the more you learn it, the lower your transient incontinence rates will be. Now that all gets thrown out the window when you're teaching residents, because if you're letting the residents do it, they're in their learning curve. And so I really struggle with that. Like, what is my incontinence rate? So if it was me, Lori Lerner, doing the case from beginning to end all along, right? And it's a little bit harder because my residents are all over the map, right? And how much you help them, what they want to do. I think, Nicole, you had said, I get my residents in year 3 and then not again until year 5, so I don't have that. They don't have that repetitive exposure. We did find that if they have neurologic disease, that absolutely was a negative predictor for incontinence, which is not at all surprising, right? So you want to be thinking about what are their comorbidities and are we choosing the right things for them, and age over 70. Right. So, and that's been shown in a lot of literature and other ways that incontinence goes up after 70, both in female data as well. So, male, female data independent of BPH surgery. So if you're getting into that older patient age group and neurologic disease status, then you will definitely see some increase in transient incontinence. Now, So right around the same time as all of this, after, I'm putting all this out, Jim then went back and looked at his, and we all published, there were 3 papers that came out on transient stress incontinence in the same year. So he looked at his 1,000 patients. Short term got 12.5%. Intermediate term, which is 3 months, was 3.4, and then long term was less than 2%. Urge incontinence was the big toughie because we all wanted to say that it was urge incontinence or mixed incontinence, and that was part of it because these patients wait a long time to get treated, and so that they do have a higher incidence of urge incontinence, and that is true. And sometimes it is hard to tease out. You guys know, you talk to patients and you can't really tell, like if they stand up from a sitting position, is it truly gravitational and stress incontinence, or did they just have an uninhibited contraction, which could certainly have happened. As they stand up, gravity gives them an uninhibited contraction, and that's why I'm kind of excited about, I'm not kind of excited, actually, I'm really excited about the Eurobright ambulatory urodynamics. I have a lot of things I really would love to do with them. And again, back to the sleep apnea, I'm so excited to put this into people's bladders overnight and see what's happening in this patient population. I want every patient who has a sleep study to also have this thing put in their bladder. So that's what we're kind of working on now to understand. So in terms of understanding where that role is, and I think that's the Botox, that's really trying to tease that out beforehand. I give out a lot of anticholinergic medication after HoLEP surgery, and I actually don't think twice about it. I just do it, and if they go into retention, I'm like, oh well, because most of them don't. And so I think that's a very different sort of philosophy than others. So, and then Mustafa, who had talked to me and said, look, you got to change your paper. He also put his out. So Jim did, Halali did, I did, and we all kind of came at this from a different angle in terms of looking at patients. He had about the same amount that Jim had, and certainly saw a strong association with diabetes. A higher volume, so a larger fossa, none of that is surprising, right? So a couple different papers look at different volumes, but basically 80, 90, and 100 have all been stated in different papers as having a positive correlation with post-op stress incontinence. Of course, it makes sense. The fossa is a lot bigger. Operative time, we've talked about whether it's manipulating the scope or is it a reflection of the larger volume. It's hard to say. This PSA reduction of 84% is really interesting. I mean, that is the surrogate for volume, right? So, but I think that this is really interesting. So think back about those MRIs that we looked at. Everybody has a very variable amount of peripheral zone to central zone. And we've all known that, right? Like, so we all talk about prostates as 125 cc's, but we're measuring the whole gland. The reality is we're not removing the whole gland. That's not what it is we're doing. And so there's a real variation in central to peripheral zone that we're really understanding so much better now because we're doing MRIs, right? So I'll sit with an MRI because I feel like I'm at the VA. They've all had elevated PSA, so they've all had an MRI, and they've had a CT, and they've had an ultrasound. So we have 150 patients right now on a big spreadsheet where we have transrectal, transabdominal ultrasounds, the radical prostatectomy specimen, an MRI, and a CT scan because they, had a hangnail and they got a CAT scan. So we have all that data, and we're looking at it to see what some of those variations are in terms of sizing and understanding formulas a little bit better. But that reduction, so to me, that actually says that a lot of these patients did not have a lot of peripheral zones. So you have to think about what that is. If you're taking out 50% of a gland because it's sort of equal peripheral to transitional zone, there's just more bulk. There's more resistance in that fossa. So there could be something there as well. In those patients who really don't have much of a peripheral zone, would you alter your procedure a little bit more? I don't know, but it's worth thinking about. Why does stress incontinence occur? Wait, what time? How long do I talk till? Okay, good, thank you. We were talking about this at lunch. I'm very much a stickler, and there's no timer up here. So I am trying to respect time. So why does it occur? I think we all have a lot of beliefs. I think there's probably truth to all of them to some degree. How much all of them come into play with each patient, I don't know. I don't know. Like, a lot of this is common sense. A lot of this, and I feel the pain of being in the operating room for a long period of time in your learning curve. When I really started proctoring, I said to people, you need to set a limit on it and you need to convert. Going back to what Joel said, you got to stop. If you're hitting the 2.5 hour mark, then it's time for you to do something else. Like, don't keep a scope across the sphincter, manipulating. You've lost your mojo at that point in time, and it's just not worth it. At that point in time, just convert or stage it and come back later. And I do think that doing a lot of manipulating in the in and out and all of that does dilate the sphincter, right? So I think that there is a component of that. So pressure on the external sphincter, dilation of the sphincter, and whether or not you're causing some temporary hypotonicity. The width of the fossa just proximal to the sphincter. Of course, these all make inherent sense. You got a huge prostate, you have a huge fossa. When you do an open prostatectomy, what do you do to the fossa? If anyone's ever done an open prostatectomy. If you do a robotic simple prostatectomy, what do you do to the fossa? You imbricate it and you close it. Exactly. We don't do that in HoLEP. And I still, and it is, obviously I'm an enucleator. It is the one thing that I will say to myself, is this a negative thing about enucleation? Like, is there a certain patient that needs to have that fossa closed? I don't know. That is a difference between us and simple prostatectomies. You do imbricate it and you do close it to a degree. So you make that smaller, it's not quite as wide. So that could be part of it as well. Loss of integrity. So patients who have big prostates, who may have been doing a lot of valsalva avoiding, maybe putting a lot of pressure on their pelvic floor, and they just don't have a functional pelvic floor. But we don't know that they don't have a functional pelvic floor because we're not measuring the function of their pelvic floor beforehand. And then we enucleate them and their pelvic floor is trash, right? Much like, what happens with those of us that have had babies over time, and all those various different things. So there are some patients who have a dysfunctional outlet, pelvic floor. I have learned that it is really important to do a rectal exam and check pelvic floor tone. Nobody does rectal exams anymore. Like except me. Like, this is a weekly conversation at our indications conference that I have with the residents all the time. Did you do a rectal exam? Did you do a rectal exam? I mean, people go out of their way. Like, the amount of excuses I get for why they did, I'm like, oh my God, you're a urologist and you're going out of your way to explain to me why you didn't do a rectal exam, which means that you thought that maybe you should do a rectal exam. So do a rectal exam. Like, I trained in an era where everybody got a rectal exam. Like, we used to have prostate cancer the weekend events where the community just came in and that's all you did. You did like 300 rectal exams and PSA tests, and everybody wanted to get on the blood draw. That was my history. I think it's important. I've had enough patients now where I've gone back and they just have no tone. I mean, you do female slings in that. I do think there is value, especially with the big prostate, rectal exam and checking their pelvic floor tone. What because you might say to them, hey, you're higher, let's think about that, how pelvic floor physical therapy in advance, like you really think about things, that tools that are available at that time. You don't have to learn about one paper that looked at the maximum urethral closing pressure, and this is that, right? Like, that's exactly, if you're not in urodynamics, the easy way around on yourself, try to check their valsalva pressure. It's not, gives you some idea. Morbidities, like we said, diabetes, neurologic disease, and obesity, all those things make sense. Come up with a bunch of other things too. This is a patient of mine. This is exactly what he looked like at his, and that snow globe was after getting his bladder, and I'm finally like, oh, done. Okay, this is the best picture. But what's really interesting to me, gosh, yeah, you're right. Where is the screen? Oh, wait, is that not a? Okay, so if you look, you can see the bladder. Do you see the pale mucosa? That's a prostate that's actually coming up through. How wide his patient's bladder neck is. So you have the prostate that kind of brings the bladder neck with you. This one is the prostate is back in the fossa and it's coming up through the bladder neck, and he's got this big wide bladder neck, right? That already has happened just because of the way his prostate is. And this was his ultrasound. Now, the tissue that you see, this is the best picture I could get of his bladder neck. The tissue that you see on his left side, that's actually all anterior. So if you saw the sagittal view, you would see that that is anterior tissue. So when you start talking about like some of the techniques everyone has talked about, and blocked, how much of that anterior tissue. So Joel, I'm not in Joel's camp. I absolutely have taken some patients back over the years that have had prostate tissue. It is almost always anteriorly. It is because I have cut it short there anteriorly and they have this big falling down. And it's rarely causing obstruction, but it bleeds. I swear to God, it's like the body says, I'm this little bit of prostate tissue, feed me. And they're getting really vascular, like, right? And then they have this vascular area up at the top. I'm always amazed at these like big ectatic vessels on this thing. And I'm like, why? Why? And this is like Nicole, we were saying, like, why does somebody's prostate grow like that? So this guy also had this anterior tissue anyway, but he also had an elevated PSA. So we got another MRI. Anyways, he ended up having prostate cancer, and this man went on to have a radical prostatectomy over at Brigham with Mark Preston. And I had sent him this picture to say, okay, be aware of the bladder neck. I'm like, I would like you to see what this man's bladder neck looks like, because you might have to do a lot of reconstruction. So, and Nicole, I don't know if you were at a fellow there. I just remember fairly early on somebody from Indiana saying that he had to do, when he started doing these prostates and these post HoLEPs, that he had to figure out how to sort of navigate the wide bladder necks, because we do. So, you know, when you're learning, you don't want to go this way and go this way. It's a butternut squash. That's why I say, everybody think butternut. You got to come around the other side and come in. I'm like, butternut, butternut. They're like, what are you talking about? So I'm like in the back, I'm like, you're at the neck. Because you got to roll it in and come around the other side. And this guy had a big prostate. So, and you can also see his peripheral zone on the left side. And the right side, there probably is some central zone there, but I actually think that most of this on the other images did look like that was largely peripheral zone and not all transition zone that you see there. But that bladder neck is really interesting. So you can see that we did butternut. We came in and we did, you know, come in this way, but you have to think about that. So these are all reasons of why these patients can have incontinence. But I don't think we lost the integrity of our bladder neck. That's why I kind of love this picture. And actually, there's another picture you're going to see shortly as well from a study that Mitch did that has that same sort of look of that diving board at the bladder neck that you see. So how do you mitigate risk? Okay, so limit time spent during the learning curve, like I was just talking about. I really think you just got to set a limit to it, because you're also, by the time 2.5 hours has passed, you're frustrated, your back hurts, you've got HoLEP posture. If you sit, I sit. Everyone's doing this all the time, you know, and you're watching them sitting there, and you know, there. So I'm like, okay, you got, just move on, just do something else. It is fine. Yes, consider converting or doing stage procedures. Start small, but not so small. I think it is true that the perfect learning prostate is 60 to 80. Now, that said, it's not every 60 to 80, but I do think that 20s and 30s can be very challenging. And I think that the risk is that you actually go much deeper and you actually go to prostatic capsule and not to surgical capsule, because you assume that you're not there yet. So when you see it, you go more, and then you've gone too far, right? You know, so I do think the small prostate could be too small. Modify those the enucleation for lobes that go past the viru, so you can leave wings. I leave wings. Sometimes those wings mean that I'm actually cutting into prostate tissue, and I will just leave a wing. Going back to Shaheen Tabatabay's talks about PVP and leaving wings there. If they really extend down and you pull back by the sphincter and the sphincter just looks kind of dilated, it's just bigger at that area. So I actually personally will purposefully leave some tissue there at the bladder neck if it looks like it extends along past that. Avoid the wide apical mucosal incision. So this is what you've seen a whole bunch of people showing, that they make the mucosal incision more narrow and then you come out beyond that. So, you know, that is like demarcating the where you're going to go early on. When I was in New Zealand, either Mark or Peter told me about Cressy's dots. So Creswell he was another urologist, and he was in Rotorua, and he would leave these little dots about where you want to go, Cressy's dots, and same sort of idea. Here we are years later, and never published Cressy's dots. Early release at the apex, so you're not doing as much manipulating around the apex. You've heard about that. Anterior to posterior dissection has been published as one of the reduced risks. I really think it's more related to skill, which we've all talked about in experience. Retrograde versus antegrade anterior incisions. And then Tev Aho and others will really talk about adjusting the settings back by the viru. 10 minutes, thank you very much. Thank you. So, and I started doing this about 3 years ago. So one of the things that people used to complain about enucleation, and again, I feel like, you know, now I've had, 24 years of being at AUAs and thinking about enucleation, was that people would complain about the mechanical effect of the holmium. So what the holmium does, which is why it works with stones, is because it causes a mechanical disruption of the water, right, which then can help fragment stones. When those bubbles and that disruption of the water gets right into the surgical plane, it shows you your plane. I mean, it opens up right in front of you. I mean, all of you here, you know that when you're there, it just shows you where you need to go. That can cause some bleeding. And so people are like, oh, it causes more bleeding. You don't see that if you use if you use a diode, if you use a green light, if you use any of these other things, you're not going to get that. But that's the idea behind it. And so Tev talks about reducing the settings to 1.5 and 35 to get more of that mechanical, almost lithotripter-like effect. I always say to like shoot bubbles into that plane to identify that plane. So I actually have started to do that, and it shows me that plane and shows the residents the plane very early on. So I'm a 2 and 50 person. You know, I trained with Peter. I'm 2 and 50, 2 and 50. The idea of the 2 and 50, you're going as high as you can to almost make a pulse laser as continuous wave as possible by sending that pulse out before it fully recoils back into the machine, right? So the lithotripter is it sends it out, it relaxes, sends it out, relaxes. When you increase your hertz, you don't recoil completely before the next pulse is coming out. So it reduces the amount of disruption and turbulence that you get. So if you go back and you actually create turbulence and disruption, it can help you identify the plane. Downside is it can identify the plane around a nodule. So if it's a very nodular prostate, it will just show a nodule and you'll be all excited and it will almost kind of birth itself all on its own right in front of you. And then, but if you just go grape by grape by grape, you're going to be there for a long, long time, right? So anyways, it's just something else to think about. So sphincter grading. So this was the paper I was talking about that came out recently. So these guys tried to see if you could grade the sphincter after early apical release. I will admit that I'm a little confused by the paper. I think that it may make sense to other people a little bit better, but I do sort of get it. But anyway, they graded it based on how they thought things looked and did find a correlation with stress urinary incontinence. And that if you had this sphincter grade 3, you were more likely to have persistent stress urinary incontinence at 3 months. So this is what that looks like. I would say if this is interesting to you and this is a very recent paper, you know, take a picture of this and take a look at it and like look at the legends that go with this to kind of help explain. I mean, I do see how one looks wider than the other one. You know, like you can get a sense of how it doesn't look the same. I struggled a little bit on this based on the appearance because I believe that this is based on mucosal appearance. And so I don't know how much that that means that they went deeper or, you know, so.
So I talked to Scott. My editorial is Mitch doesn't want to change what he does. And so Mitch is still a traditional 3-lobe encircling.
Which is mostly what I do as well, yeah. There you go, Joe.
Mitch doesn't want to change, but Scott has gone to an early release. So this is their second study really looking at this, about transient incontinence and what's the mechanism. And so they were definitely looking at those, like in C, you can see that big run of mucosa on the left-hand side of the image.
Yep.
And that's like a traditional encircling tag that we all would see, and everybody ends up.
And I would worry more about a stricture than it being a true deficiency of the sphincter, but
since they're doing it differently now, this was Mitch's second take at it, really doesn't make a difference, and it does.
okay. So anyways, I encourage you to look at it, get a little bit more description from the paper about how they determine how they graded it. But what I wanted you to see in this picture is if you look at B, the top right one, it's that same bladder neck like what I showed you on that other picture, you know, so it's that same sort of you enucleate, and in this case prostate came up a little bit behind the bladder neck, and you get that little bit of a divot. And if you've seen patients post-resume, you can see that if they have one of those middle lobes that extends behind the bladder neck, they almost have this big like diverticulum behind there, and then there's what you think is a trabeculation, and it's that's actually the bladder neck, like this thin area of the bladder neck, and there's this big defect here and this big defect. on top of it. So anyway, so people are definitely trying to look at this to see, what if there are approaches that make a difference in terms of incontinence. I was just quickly going to spend a little bit of time talking about how do you manage stress urinary incontinence after HoLEP if you do have permanent incontinence or a patient who remains bothered. I'm a big user of imipramine. I use imipramine a lot. I do think that is helpful. I start at 10 milligrams at bedtime. I then increase them to 20 milligrams because the pills come in 10s and 25s. I go from 10 to 20 and then 25, or add a 10 milligram in the morning. A lot of patients, when they get dry, I take them off the imipramine. They ask if they can go back on it because they slept better. So whether or not it's doing a little bit for because it has both some pathomimetic and anticholinergic effects. So it has both a little bladder relaxation as well as alpha agonist activity. Alpha, no, not agonist. Alpha activity. Yes. So it actually will tighten. It would tighten it. Oh, good Lord. So I was right. Okay, there you go. Thank you very much. So imipramine is definitely, and Sudafed is the other one, but Sudafed is much more drying than, but Sudafed can work if they want to take something just for the purposes of playing tennis or something like that. You can tell them to take 30 or 60 of Sudafed. So imipramine is one. Urethral bulking agents. So I've used coaptite. Bulkamid, there's definitely some publications out there talking about Bulkamid for post-endoscopic prostatectomy incontinence, not just HoLEP. Bulkamid is probably a bit better than coaptite, but you have to have enough real estate. So if you don't have enough real estate in their fossa, and the thing about enucleation is if you're going to capsule, there's not really a good place to put it. Whereas if it's like a TERP or something else. Now, if you leave wings, like you might find some real estate to put something in that you can add a little bit of a bulking agent. Male sling is certainly out there. The ProAct perineal balloons. I have one patient, I'm going to show you his picture, and then of course the sphincter. Oh, and pelvic floor physical therapy is really important, and it's making sure that they do pelvic floor physical therapy correctly, which many of them don't. So this is a patient this is a great patient. So this patient, 250 cc prostate. In the end, I ended up resecting 170 cc's on pathology. At least that was weighed. So I think there was some discrepancy in the measurements, but you can see his CT scan. He didn't have necessarily a very big intravesical component. It was mostly all within his sort of deeper pelvis, if you will. He'd been valsalving to void for a long time. So he is a perfect example of somebody with decreased rectal tone who was just so miserable. I went ahead and operated on him and did not appreciate how much this was really going to be a problem. So he's a very fit guy, 64, I think, 65 when we actually did the procedure. So, and he developed post-op incontinence, but he was like the happiest incontinent man ever because he still said it was easier to void. But then he had to wear a Cunningham clamp at his daughter's wedding, and I felt terrible. And so I did coaptite. He was dry for like 2 days and thought it was great, and then it failed. So we did it a second time, and then I was like, and then it failed. So then we did a male sling, and then that didn't work. And I'm like, oh my, but he's happy as can be. He brings me chocolates every time, and he's like just the nicest guy. So finally, he's like, a year and a half passes and he's like, yeah, you know what? I really want to do something. So I did a ProAct on him. But this is what his fossa looks like. I mean, honestly, I can't not see a mushroom in Hiroshima every time I look at this. Like, it really bugs me. Like, that's what I feel like it did. But what I want you to see is at the bottom there is you can see the tissue I left. So I left him, like, you can see where his sphincter is on his right side. Like, he comes to a complete stop. And on the left side, clearly I left a little nodule that's sitting right there because you can see the filling defect there. And when you look, he can coapt his sphincter just fine. It's pink, it looks gorgeous. You know, other people have looked at it and he just can't keep it closed. Like, he just loses tone after a while. And it was just devastating. So I talked him into being my first ProAct patient. So we put in the 2 balloons, had really, really good placement of the 2 ProAct balloons. This is how it looked like just before his final installation. So on the left, he has 1.5 cc's in each balloon. On the right picture, we had increased him to 2 cc's, and then he came in one more time after that, and he got increased to 2.5 cc's. And now he likes to tell me how he can walk around naked in the woods in Maine and build his benches. I'm not sure why you need to build benches naked, but That was the most recent text, along with a picture with his grandson. So that's how it looked at the end. So I had a really good result with that. So in conclusion, so I think the most important thing is track your outcomes and just see if you can find some unifying factors with the patients that you're seeing where they're having some incontinence, and just try to do some honest, like looking at your own data to say, what is it about this? And don't, not in a self-deprecatory way, just in a very, is there something that I should be doing a little bit differently of this patient or because of me? Or comorbidities, if there's anything that needs to expect those planes, and particularly at the, look at Mitch's paper, adopt some of what presentations that have happened earlier today, operative times, and just try not to tackle those large, make you defy all the things at the beginning. And that's it. Yeah, right on time.
A comment more than anything else. I think talks like this are refreshing, so I appreciate it. Love, probably agrees, maybe not. So I might be putting my foot in my mouth. Love Dr. Lingeman, one of his mentors. I think one of the challenges in training like that is that no one leaks. Truly, no. There are no reoperations. That's a challenging thing to hear and experience, and then go out into practice and seemingly have everybody leak. Now, part of that is it's a large, doesn't see a lot of these people back. Settle out at some point. For people that are learning, me would be one of the biggest deterrents besides the steep learning curve and the sweat equity you have to put into it, is that people come back and at 8 weeks they can be maybe not super happy sometimes. And so really calling it what it is and
you
encouraging people to look at their own data, and underselling to a bit, rather than, and then over delivering is, I think, a really, really key thing from your talk.
And you do know that Jim doesn't have 100% continence rate, right? It's just, so I feel.
That's what you say.
But you're right. It's because if they leave and they don't come back and you're not following them, it's hard to put everything into context to really understand that. And I think that was the point of all this at the beginning, is we have to be honest about it, right? Like when you do become a referral center, you may not follow them. You may not hear from those patients. I get even within my own VA, because we manage patients as a group, the residents, if they don't put me as a cosigner on a note on a patient that they've seen that's come back, I don't even know. And then I might find out 3 years later that this guy's been having urge incontinence or whatever. Or they finally say, hey, he's having some leakage, and I'm able to fix it like that because I think about it differently than they think about it. And I didn't even know, right? And they're in my own hospital. So I think it is hard to track it. And it happens to all of us. I mean, we definitely have it. And I think it is hard to know what your own true rates are, even within your own practice. But yeah.
So I think that one thing common is that I think that one of the pieces that's missing in some of the early literature, and Casey and I were talking about this last week, is our consistency in assessing preoperative incontinence is missing.
Yes, 100%.
I mean, Scott Querier just like literally 2 weeks ago presented and published this, that 10% of our patients are incontinent before they have their HoLEP. 4.5% are incontinent after they have their HoLEP. So actually, HoLEP improves continence because you're addressing all of those guys who have horrible storage symptoms and bladder dysfunction and urge incontinence. And you're right. Second comment is I tell them 20 to 30% for their transient incontinence. And the third thing is don't see them until 3 months.
But the data that you're talking about, that the patients who had incontinence before, who have incontinence, are not necessarily the ones who were incontinent. So it's not like you took the 10% that were incontinent beforehand and now they're 4.8%. That 4.8% is largely a different group. And the 10% may be completely dry. Could be, right? Yeah.
I actually looked at that. And so same thing as we all say, right? Like there's an increase in their incontinence for about 3 months and then they return to baseline.
Interesting, yeah.
Do you ever see those patients who don't seem to have true stress incontinence? It's more like the seepage. No, they void, and then they seem like they empty.
Yeah, I do think that you can get trapping of urine in the fossa. So I do think that can be a little Do you call that stress incontinence? I mean, you can call, yes, might call that seepage or leakage, but you can get trapping of urine. Some of these really big fossas, that can just happen. Also, if they end up with a big divot behind the bladder neck, because they've got a prostate that sort of splayed their trigone, and you've taken that, then when the bladder collapses, it almost traps some of that underneath there behind, because it compresses down on top of it, like almost like a little tick. So I do think those patients can get a little bit, I think that's coming from the fossa and not necessarily from the bladder, because when you listen to how they leak, and it literally is like a squirt or a drip, those are the things where you can look at. Maybe there's a bulking agent that you can put in there in a really particular area, but getting video urodynamics in that case, or just a video cystogram, just a VCUG, can give you some of that information in the oblique to see. Because I have seen patients with a big fossa, their bladder neck closes, and they have this little trap of contrast that's sort of right underneath behind the bladder neck.
So I have a question. I want to go back to the rectal tone, the DRE. Right, I never thought about that, but that makes a lot of sense. And maybe Ann Cameron can comment on how rectal tone correlates with incontinence. Is there any strong data there? But my surrogate is that the guy who's sitting in a wheelchair. He's 94. He's got a Foley hanging out, and his family wheeled him in because he has a Foley in and he wants a HoLEP. And I look at him and go, "You're just gonna leak." But it's the same sort of thing. I bet you if I did a DRE on him, he's got like no tone at all because his whole body is shot. So Ann, is there good data for doing a DRE rectal tone correlating to incontinence?
So the Learn network we did 1,000 patients, half men, half women, with a LUTS, and we did grade pelvic floor muscle tone in both men and women. The problem is that we're all terrible at grading tone in men. We're really good at it in women because the resting tone of the vagina is actually pretty low, and you can get a woman to contract her pelvic floor with some coaching, and it's the same grading system you use for any other muscles. The Oxford grading system: 0, 1, 2, 3, 4, and 5. 5 is not normal in the vagina, by the way. And in the rectal exam, the problem is that a lot of guys are at a 5 because they're pretty upset that some chick has their finger up their butt. So it's hard to differentiate between the two. But, I do agree, though, and it's not the anal tone. It's the pelvic floor muscle tone. So it's not anal tone that we're talking about.
Yeah.
Right. So I do think it is a marker of frailty. I mean, I do a lot of rectal exams because I see both genders, and it's a marker of frailty. Interesting study on one of the strongest men in the world. He's a guy who can deadlift 1,000 pounds. He's gone through cycles of inactivity and activity, and he lets science measure his body. So he'll be inactive for 6 months and then train really hard, and they'll image his whole body. The two parts of his body that gain the most muscle mass in intense training are his feet and his pelvic floor. Fascinating. So I do think that there probably is a way of grading it, but I think unless it's really horrible, it's pretty hard to detect. But you know what I mean, that 90-year-old guy who can't stand his pelvic floor tone is pretty bad.
Peter, you were going to make a comment too.
Yeah, I was just following on Joel's point about the early studies not mentioning continence. And I just looked back at our 2003 randomized trial, which was the first of the HoLEP versus TERP ones. And I'm just reading here. Incontinence was present in 48% of all cases beforehand, 48% in the HoLEP, and 33% in the TERP cases. And afterward, 6 out of 15 HoLEP cases resolved, and 8 out of the 11 TERP cases resolved. And there was only one patient with de novo stress incontinence at 12 months in the HoLEP arm. So in the early cases, we did look at that. We did look at it.
Really quick comment. Because
Listen, I think we need to talk about it, right? This is one of the biggest things that we need to talk about. So, and I don't want to talk about ejaculation, so just keep going. Keep going so I have less to do on the ejaculation. It's going to be a silent study presentation. Go ahead.
One of the things I probably started doing in the last 5 years, first of all, I cysto everyone before I do a HoLEP because I don't want any surprises. I've been burned 1,000 times, feels like, and obviously it's once or twice, but it felt like 1,000. So I cysto everyone, but I actually have them, as I'm taking the scope out at the end, I have them do a Kegel so that they can see what I can see how, if they can co-opt their sphincter, and they can see it, and then I can also like coach them right there, you know, in the office as to whether they're doing. Now, granted, they're laying down, I get that, but you know, I think it's like a good teaching component, because I have them all do Kegels before surgery and then again after, as long as they don't have catheters in. And there's been a randomized trial that says that that makes a difference.
I just wanted to follow up on that. So what is the degree of education you're giving about pelvic floor physical therapy leading up to the surgery? And is there preoperative pelvic floor physical therapy counseling, like with a physical therapist? Or
So in our practice at the VA, no, there's like no counseling beforehand. I do think that if people are developing BPH centers, you know, that could be something that could be considered if you're following this sort of sling data. I definitely do counseling about it, to talk to them about it, so that when it happens during surgery. So if I do a cysto, that's one opportunity. If we're doing Eurocuffs where they stop and start their stream, they have an idea behind that. So you can do attempts at counseling. It is really hard. Most patients don't do it correctly, right? That's the other thing, is that to really have a patient do pelvic floor physical therapy correctly, they need someone who's really coaching them and teaching them. You know, if they think that they can get it off of a YouTube video, they're probably not doing it right. If I don't know if anybody in here has tried to do Kegels, but I can tell you that saying that you can do a Kegel and hold it for 3 seconds, I can't hold it for 3 seconds. I mean, they move their thighs, their butts, their abdomen, everything but their pelvic floor, right? You know, and I'm probably the same way, right? They're like, everything's moving, and I'm like, but nothing's happening down there. They're like, you know, I'm just like, okay, let's try again. Like, you know, try to make sure they're actually doing it correctly. So I do think that education about it is hard, and maybe it's easier for men, but when I have these men go, oh, I do Kegels all the time, I can hold it for 10 seconds. I'm like, well, then you are definitely not doing it right, because it's really hard to be able to hold a pelvic floor contraction for that long. So I think there is value if you think it's an at-risk patient to having them go. It's also very hard to find good pelvic floor physical therapists for a lot of us, and that's part of our big problem.
Yeah, so what we do is if we can get them, it makes a difference if you can get them even one session with
Yeah,
a
I bet
pelvic
it
floor
does, yeah.
PT preoperatively. Because in one session, they can at least understand that they are not supposed to do, because guys do two things, right? They Valsalva or they do a glute contraction. They have no idea what a Kegel is. And so if we can get them at least one session with a pelvic floor PT, it will make a difference. And for those at-risk patients, and in our practice, if they have a high frailty score, if they have any sort of neurologic disease, or you know, if they're just like John's describing, the guy who comes in, you know, in the wheelchair, like if you can get them at least one session, at least they have some concept of what they're supposed to do. Because patients are exactly like Lori said, like, oh, I can do a Kegel for, I do them all day, and they go,
They're like this, they're like, you know, like everything's moving.
I'm like,
Everything's moving.
I
except
literally
the pelvic
asked
floor.
them, I'm like, oh, you're good at Kegels, show me. And they do this.
That's totally it. That's totally it. Cracks me up every time.
It's like they're having a seizure.
Or they stand up, your fingers in their rectum, like you're checking, and all of a sudden they like stand up, and you're like not expecting that, and your hand goes up this way. I'm like, okay, that's not it.
And to Mike's point, you know, my first move with those guys who are like, you know, it's the perfect storm, right? Their AUA symptom score is a 1 and their bother score is a 6 because they lose 6 drops of urine after they urinate every time. Whether it's the fossa functioning as a cistern or whether it's bulbar urethral trapping, my go-to first, even before we test them, is teach them how to do urethral stripping. You know, milk from the bulb, don't shake your glands because it does nothing for that bulbar urine.
Is everyone awake now?
If people want to know the proper prompt, there is randomized control studies on the proper prompts to give people to do a Kegel. And for men, it's you want to pull the turtle's head into his shell.
Okay.
Pull the turtle head
See,
into
I always
his
say it's
shell.
like there's an egg in your rectum and you're trying to crack it.
Yeah, so that's going to be the anterior part
Yeah.
of your rectus, if your pubirectalis muscle, but it's pulled it. There is in
Okay, so both
women,
of those
there
things.
is the knack maneuver, which if you can PT, have them learn the knack, practice 10,000 Kegels at elite class, and they're not. to do the Kegel just before you sneeze, just something up. So you recruit and then recruit an action, and it'll cut incontinence like with one teaching session, one little teeny weeny thing. Turtle in the shell.
Turtle in the shell.
Turtle.
So,
Or try not to fart.
but see, well, that was my like. You're trying to crack it. Like that's.
I think that needs to be on a T-shirt.
Never say teeny weeny.
Yes.
Thank you, Laura. Our next speaker is Borirakchanyavat. And I guess the reason I can say his name so fluently is because we've known each other forever. After CSF, did his residency and then went right to Kaiser, time job. He's got promoted. He's chief of urology in Panorama City. He's been he's held a number of other leadership. And one day, I was so impressed at how it looked. And it's like, you got to check this out. A HoLEP, and it's just like what they said. Well, next thing I know, he's doing it. San talks to me a bit about HoLEP and experience. And one of the things that he told me is how you can do a perineal urethrostomy for these really large prostate, because the scope is only so long, and we struggle with that sometimes. So I asked San, oh, that's great. Come show us a video on how you do that. So that's what he's going to do.
Yeah, so it's great to be here. As John was saying, he did call me up one day, and he's like, San, you got to see this thing. He's like, this is the best TURP you've ever done. And that was the start of my journey. And I feel like there's a little bit of a full circle here, because when I first took the HoLEP course, Nicole was there, Joel was there, Lori was there. Mitch Humphreys, of course, was running the course. Joel proctored me, and I've talked to John multiple times about HoLEP and what I was doing. And so he's given me a lot of support over the years in terms of learning this operation. And so, yeah, so I'm going to talk about like the large glands, and large is just all relative depending on what you've done. But I'm talking about like something really pretty big. And so as I was preparing this talk, it occurred to me that this could come across as a little bit of a big fish story. We all like to talk about big glands that we've done, and big fishes do exist out there. And I wanted you to see. Twilight is a terrible movie, by the way. And I just wanted to reassure you, I'm not here to talk about it in a way that I think is going to establish. I don't want to do that. I want to show you that there's a way to do plans that are virtually and to do them with good results. And so ask yourself this question at the end of this talk is, am I still astounding you by what I'm about to show you? And if the answer is yes, then I haven't done the job that I really wanted to do. Because what I really want to do is show you that these glands are doable, and you're going to get good results with them. Okay, I'm also going to tell you about the stuff that didn't go as well as I wanted to, and all the things that I've kind of learned from that as well. Okay, so there's a lot of young people in this room. Do you guys remember this movie? Oh, Princess Bride. That's Princess Bride, right? So that's the mythical rodent of unusual size. And yeah, exactly. It's a real species, though. That's a prostate of unusual size, and we all deal with these when we do HoLEPs. And this is also my disclosure side. I have no financial disclosures of any kind, and all of my offshore accounts are completely clean of any urologic investments. Okay. All right, so here are my objectives. I don't think I need to convince you guys, but I really do think that HoLEP is really the best technique for giant BPH glands, and I'll define what I think is a giant gland a little bit later. I'm going to show you the cut-down PU technique that I've been using to do these really large glands. Mike is also doing these as well. Okay, and we'll talk a little bit about some tips for doing large glands and how to do them safely. And then I'm going to show you some pretty interesting indications in which they're really not large glands, but I've also, Mike and I have also done PU and HoLEP in these cases. Okay, so this is very quick. You know, the AUA defines a very large gland as anything over 150 milliliters. And really the only techniques that are recommended in that box are all enucleation techniques. And I don't have to convince anybody that HoLEP is the gold standard for enucleation. Okay, so what is a giant gland in my practice? You know, if you look at articles on what is called a giant gland, there's no consensus really. It starts anywhere from 200. Some papers say it starts anywhere from 500. And in my mind, it's really, you know, what is a gland that actually causes you to change your surgical plan and do something different? And interesting, in our practice so far, it's been a number like around 350. So I'm going to split this number and just start with a gland of like that has a resected tissue of 350. So when I show these people, this is actually the largest gland that I've done so far. This is a 750 gram adenoma. And yeah, it's really impressively large. When I show it to people, people say, you know, this is crazy, right? I think what they're really saying is that I'm crazy. And I don't think I'm crazy. In fact, John has known me for about 40 years now, and I'm definitely not crazy. I'm a very conservative person. But this is so large that actually when the patient was under anesthesia, I could actually feel this thing on his abdominal exam. So we know that this is actually like something that is pretty intimidating to look at, but I want you to take a look at this again. I really like this picture because if you take a look at how much tissue is hanging in the bladder, okay, it's not as big as 750 would suggest. It's really more like maybe a 400 to 500 gram prostate within the fossa. It just happens to have another 300 grams probably attached to it. And so it is actually much more doable than what you actually think there, than 750 would suggest. Okay, so that's the first point I want to leave you with, is that this thing's not an orange, it's actually an ice cream cone. And there's going to be some tissue which is just going to float up there and that you never have to deal with. Okay, so why do HoLEP for GPH? You know, why not do something else, like an open simple or a robotic simple? Well, the reason really comes down to exposure. Okay, as these glands get bigger, those techniques become harder and harder to do. And I've never actually even really contemplated how would you do an open simple on a gland that big? How could you do a robotic simple on a gland that big? Because you can't really get that exposure all the way down to the apex in those cases, right? So I think it'd be very difficult. The literature does bear it out too. If you try to do an open simple, let's say you did it without, presumably, without embolization, the results are horrible. There's about a 40% mortality just from the operation itself, from uncontrolled bleeding. So HoLEP's the right approach because you're starting from the apex. None of this tissue gets in the way of your exposure, and you just need like maybe a centimeter of space between the adenoma and the capsule, and you can work your way up there. The problem with HoLEP also is really one of three things. Okay, the length of the instrument you have to work with, the ability to angulate to get to all parts of the adenoma, particularly the bladder neck, and lastly, the bleeding. And the first two, the length and the angulation, are really limitations of the standard transurethral approach, and I'm going to show you how we can overcome that. Okay, so here's your average resectoscope. It's got a working length of about 18 centimeters, exactly 18 centimeters. And if you take a look back at my first example, you're going to see that this scope has no chance of reaching the bladder neck with the standard transurethral approach. It's just too far away. And if you look at, I decided to put some markers here to show you what the transperineal approach would actually do in this case. Okay, so these are the two landmarks, the anterior and the posterior bladder neck. Okay, here's the perineum here, and if we put two markers here, okay, you'll see that actually the scope that you have is going to reach this, but you got to go transperineal. And this is a 13 centimeters right to the anterior bladder neck. The posterior bladder neck is always further away, a few centimeters away, 16 centimeters. But with this 18 centimeter scope, I can get there. Okay, but you have to do the PU in this case. All right, so what about mobility? Well, mobility is another thing that you have to think about because you have to angulate into the anterior plane to get there, right? And you also have this additional posterior plane up near the bladder neck, which is also difficult. I always slow down in this area because I feel like on a larger gland, that's where I'm most likely to perforate. In one of these cases, I did perforate there because I didn't do a PU and I didn't have the angle. So I'll talk a little bit more about that too. But if I show you what I do, like when you put your scope in, you're going to assess mobility, right? Just kind of like flex your scope up to the bladder neck anteriorly at 12 o'clock, see if you can reach it pretty easily. If you can reach it pretty easily, you can go ahead and do the standard approach. But if you're not reaching that area, you're not going to be able to do the standard approach. You got to think about doing the PU. And if you cannot reach the anterior bladder neck, there's no way you will ever reach the posterior bladder neck. Once you start your enucleation, you're going to be short by a few centimeters. Okay, so here's the angle. I do a top-down approach, and so the first place I'm going to go is actually get to this anterior plane and try to get into the bladder neck. Second place where I tend to have trouble or tend to need to slow down is actually in the posterior bladder neck when you get close to the bladder neck itself. It tends to go a little bit under, and that plane's actually coming towards you, and it's no longer working away from you, right? So these are too difficult. Now I want to show you what it looks like if you did a standard transurethral approach. It looks like that. Your scope's going to be heading more or less posteriorly. You can bend it a little bit, you can deflect upwards, but in a really huge gland, those angles are really, really tough to reach. Okay. If you put in, however, a PU approach, there you go. You're actually very much aligned with the prostatic axis, and you can actually get to these angles more easily because you're actually already about 45 degrees more anterior with a PU approach. Very easy to actually reach this, and I'll show you an example coming right up. Okay, so how did I learn this? Well, it was interesting. Actually, I learned this at the San Francisco General. I was an intern, and I saw my chief resident take my second-year resident through this procedure, and he had learned it from Dr. Makinich. You know, in turn, actually, all of us taught each other subsequently. So there's a generation of us that learned this procedure, not always directly from Dr. Makinich, but from each other. And it's a really simple procedure. Everything you need is right there on the right side. You need a scope, you need a 15 blade. Okay, it's very simple. It's literally see one, do one, teach one. I saw one, I did one. I told Mike about it. He didn't even have to see one, he just did one. All right, so it's really simple to do. All you need is, depending on the urethra you're working with, a 17 to 22 French standard cystoscope, an obturator. Okay, there's absolutely no expertise in urethral surgery that's needed, none at all, okay? There's no formal closure of the urethra needed. You just put in a catheter at the end of the case, you close the skin, you leave it in for about 7 to 10 days, and it heals, okay? I want to tell you a little bit about our results. Just there's not that many cases here, but we're looking at glands at over 350 grams, so there's not really anything that, there's not going to be a lot, is the bottom line. But if you take a look at you know, our cases, we did 6 cases. I did 5 of them. Mike, because he's only been with us for 3 years, he's done 1. But it was pretty sizable. I think it was like a 500 gram resected tissue case. And we did perineal ureterotomy in 4 of these cases, okay, but I should have done 5. The one that I didn't do, I couldn't make that posterior bladder neck angle. I perforated, and I couldn't do the morcellation because he extravasated, and I had to open up to actually extract the adenoma there. So I think the number, there really was only 1 case in this range in which we truly did not need the PU. We were able to do primary morcellation in 3 cases. We didn't really have any serious complications. One of the open extraction cases, we had a superficial wound dehiscence, and that was okay. Remarkably, knock on wood, we didn't transfuse anybody. But on 1 case, we did come close, and I'll tell you a little bit about that later too. And recently, we've actually been able to do a couple of these as same-day surgeries. So it is possible to do if the case goes really well and goes fairly quickly, and you have good hemostasis afterwards. Okay, so yeah, we tended to also skew towards heavier patients in this series, and I think that may account for why we needed the PU as often as we did. We had like an average BMI of 32, and these were the ranges. Started at 358, went all the way up to 750, with a mean of 541 grams. Okay, so here's the index case I'm going to show you. He's 89. He's got a 400 gram milliliter adenoma on preoperative imaging. He also had bilateral hydroceles and hernias that hadn't been fixed for a while, and nobody was going to touch him. They're really big, right? So we had to get around that. And here's the I'm going to show you a video in a second, but I just want to highlight to you some of the key points. I put him in about a 15-degree Trendelenburg. Gives you better exposure to the perineum. You have to retract the scrotum up in a lot of cases. Either use towel clips or you use sutures, but get them out of the way so you don't have to deal with them. In this case, I'm using a 19 French cystoscope and obturator, and I'm going to make a 2-centimeter cut into the urethra directly down on the sound. And then I'm going to place some retraction sutures so that it doesn't get in the way when I'm trying to put in my scope. And the key really, I think, to avoiding strictures here is actually making a generous incision. Don't just nick the urethra. Make like a 2-centimeter incision right into the urethra. Make it obviously longitudinal, but make a generous incision. Once you put your scope in there, it shouldn't be dilating anything. It should just fall right into the urethra. Okay, so watch the video here. So here I've already placed a 19 French scope. I just felt where it was in the bulbar urethra. I'll put a little mark there so I can see where to cut. Okay, and here it is. My assistant is now going to push hold the sound in place. He's going to put a little pressure so that it pushes down towards the abdomen a little bit. And then I can see where I can feel where this sound is. It's going to be right underneath the skin. Okay. So now I'm cutting onto the urethra. I'm going to make sure I have about a 2-centimeter cut right on the urethra. Now don't freak out when the scope comes sticking out of there. Here. Okay, it's supposed to happen. Okay, there it is. Stick the scope right out. There it is, it's sticking out. Okay, and then I'm going to put a retraction suture here. I'll show you how to do that. By the way, has anybody learned this in their residency by any chance? You did, Lori? Yes, exactly. So I attribute it to Dr. McInich. Yeah. Yeah. Mhm.
I'll tell you, the urethra was so easy to see in the period. I mean, exactly, because that was the one thing that was so nice about the peritoneal prostatectomy.
Yeah.
It's like right there, the urethral anastomosis is just a piece of cake.
Yeah. Yeah, it's interesting because I attribute it to Dr. McInich. He never claimed credit for it himself, but we just thought this is such a McInich thing to do, So the next thing you need to do is actually just kind of like railroad the two scopes together. You have to like make them kind of like one unit, okay? And it's a very simple thing to do. This is a 22 French scope, like, you just railroad it to the outer sheath of your 26, and now you're ready to go, okay? So, but this is really key because you want it to go exactly where you want it to go. If you try to look in and try to find this, you'll never find it. It's really interesting. I've tried to do that just to see if it will work. You never see the opening if you actually didn't do this. Okay, so now that you've locked it together, you're going to insert the tip of the resectoscope into the urethra. But remember, when you do that, you're going to be looking antegrade. That's not where you want to go. You want to look retrograde, right? And so you're going to confirm visually that you're in the urethra. You're going to pull it back, and then you're going to tip your scope downward, look down the urethral lumen, and then enter the bladder. So let's watch this here. Yeah, so he's going to help me a little bit because I caught my own clip here. So there it goes, okay? It goes in about maybe 3 centimeters, and now I can feel it just kind of enter the urethra. And I have my visualizing obturator ready to go on the abdomen, pull it, reassemble my scope, okay? Right. Yes. Yeah. Oop. Oops, sorry. Yeah, I'm sorry. I was trying to. Could you play this slide again for me, or should I just go back one and then there it goes? Okay. Yeah, sorry, I didn't know how to stop this thing, so I wanted to just wait for Lori's comment there. But I'll pick it up here as we do this again. And when I first saw this as an intern, I thought this was like the slickest thing I'd ever seen. I was like, this is so slick, I'm gonna need to do this someday, you know, and I actually don't, but you can send them to Mike. But you know, if I got them, I talk to them about this. Yes. So here I'm going to run the irrigation here. Okay, I'm going to run the irrigation, and I'm just going to visually confirm that I'm in the urethra. Okay. And you just take your time with this. There's no need to rush it. And you can see on the screen that kind of looks like urethra, but let's confirm that I'm in there. Okay, you're going to be able to see water coming out, the meatus too, as you do this. Okay, and there it goes. I think I'm in the urethra now. Let's confirm. Yeah, there it is. Definitely urethra. I'm going to now start pulling back, and you have to pull back to the urethrotomy location. You have to pull it right back there before you can turn. Okay, so I'm going to pull back. You're going to see like a little cut edge of the urethrotomy on the right side there. Right there, you see it? Okay, and now that I know where I am, I'm going to now just tip my scope downward. You'll see my hands coming up. Scope's going to point down. Boom. There it goes. Okay, now you can look back up again and be in the bladder. So I've done this also for like very anterior bladder tumors, big guys, all those kinds of anatomic problems. But it's really helped me a lot with HoLEPs. Now this guy actually, I tried the standard approach in the beginning, nowhere close. I couldn't even actually get out of the prostate fossa. But you can see how easily I can actually go in now. Here I am in the prostatic urethra. Okay, there it goes. You know, and it just made the rest of the enucleation really straightforward. I didn't fight any angles. I wasn't trying to, you know, get to it. I wasn't trying to force anything. It was just easy. All right. Yeah, you'll end up with a tear. At the end of it, when you put the catheter in, you may or may not be able to feel the catheter. It doesn't matter. In this guy, actually, I could feel the catheter, which means that it probably did stretch that opening, you know, as I was doing the case. But he did fine. He did really well. So here's a summary. I did the case in a little under 4 hours. I got out almost 400 grams of tissue. I was actually able to discharge him home from the recovery room. I left the catheter in for about 11 days, and you can see this is the urethrogram. I don't really think you need to do a urethrogram, but since I know I was going to give this talk, I figured, you know, I'll do one just to show everybody that this does work. You don't have to close anything, just put the catheter in and it'll heal, right? And so, all right. So PU and HoLEP, beautiful combination for really big glands, really big, okay? And it's really allows you to do any size gland, and I believe really in any size patient. I haven't seen a patient yet who I think I'm not going to be able to do with this. It's really simple to do, really quick to do. Literally, you just saw one, so now you're ready to do one, right? And then you can teach one, but really good. You know, in our series, we did not have any major complications. Everybody did well. There were a couple unanticipated things, and I think I mentioned that there was a patient who had to open up because of perforation, and it really was because I didn't have the right angle, and I was trying to do it without the PU, and that was a 358. And I should have done a PU on him. If I'd done it, I think I probably would not have opened that patient. So far, we haven't transfused anybody, and we were able to do like the two most recent patients as outpatients. All right, so I think I'm going to talk last about bleeding. Okay, these things can bleed. The really big ones can bleed, and I've come to respect that because I was so used to just doing hemostasis with a laser and getting away with it. And you know, every now and then you have like a little red out, but eventually you get a hold of it. But in the 750 that I did, I could not use a laser a lot of times. I just could not see well enough, and eventually I had to switch back and forth with the 750s on the left side of the screen, by the way. So I had to switch back and forth to the bipolar probably like a dozen times during the case. It made the case really long, and it was also really bloody as well. And it took me over 6 hours to do. The patient stayed in the hospital for like 2 days and dropped his hemoglobin by about 6 points. You know, he did fine. I didn't transfuse him eventually, but had he dropped a little more, I probably would have given him a unit of blood, right? And so I kind of thought about it a little bit, and I was pretty proud that I got the 750 out. But then I kind of thought to myself, and I said, you know what, I can't do that again. I'm not doing that again. You know, this is too much blood loss, and I got to come up with a better approach. So a year later, I got this guy on the right referred to me, and I measured him like, around 600. He actually turned out to be a 700-gram adenoma. And about 3 weeks before the HoLEP, I actually had him do a PAE by IR. And the results was remarkably different. It was like I was doing a totally different kind of case. I didn't actually, believe it or not, he was a normal build guy, so I actually did not do a PU on him. But if you can look at the case, I was done like about 90 minutes quickly, more quickly. The hemoglobin change was probably about a quarter of what it was with the other patient. And I actually discharged him from the PACU same day. So he didn't even spend any time in the hospital. The other thing that was really interesting too, which I called John about afterwards, I was so excited, was because like when I got in that plane, there was already some like edema in that plane between the adenoma and the capsule. It was almost like somebody had gone in there and like very nicely hydrodissected the entire thing for me. So I actually just kind of flew through the enucleation. My resident did part of the enucleation. It was really very, very straightforward. It was really the driest, big gland that I've ever done. So, it's really changed my practice. I'm really looking at these really big glands as saying that really, they should have probably preoperative PAE beforehand. And I think it really helps with control of the bleeding. I want to go over a few other cases that I thought would be interesting for you to see, because it's not just the big glands that are going to need a PU. There's going to be other indications. This is a patient of mine who had a BMI of like 51, and he had a really long prostatic urethra, and it's also, you can see from the CT scan, really anteverted. This is still one of the hardest HoLEPs I ever did. It was one of my early cases, but I remember that. He also developed, he's the only patient I can recall who developed a stricture after a PU in my practice. And so about a year later, I had the pleasure of going back and fixing his stricture, but he did great, after that. But I really think the strictures are technical issues. Probably I went in there and maybe I didn't have a big enough incision, but I probably caused more trauma than was needed. And I think that's probably avoidable if you make a bigger incision when you do this. You don't see a lot of malleable prosthesis anymore, but this was one of them. This is a guy who needed a HoLEP. He has a malleable prosthesis. Only way you can get in there is do a PU and a HoLEP, right? Yeah, this is an interesting variation. It is what I call a no-go urethra, named after the Japanese professor, Dr. No-Go, because there's no going through this urethra. Okay? You're only going to find this out at the time of your surgery. You're going to try to put in your 26 French scope, and you're just going to run into a narrow urethra like a couple centimeters in. And this guy's got about a 22 French urethra. I tried to do the standard approach, ran into this no-go urethra, and I did a PU and then HoLEP. I did a urethrogram just to, but that's the segment right there. It's about 22 French. And this is the area where I did the PU, and it was healed by the time we did this catheter removal. Okay, here's another interesting case. This man saw me about 5 years before his HoLEP, and he was actually a patient who had a proximal hypospadias. It was obviously repaired when he was a child, but he had a very narrow focal stricture in this area. And I did his urethroplasty, opened him up to about 17 French or so. And he wasn't going to get any bigger than that. And so when he came back a few years later with BPH symptoms to do his HoLEP, I knew I wasn't going to put my scope through that area. It was just impossible. So I used a 17 French scope, put it down through this area, did the PU, and then did his HoLEP, and he did great. Okay, this is one of Mike's Fung's case. So this is Mike's. And this patient had about a 200 gram prostate, and he has also severe lower extremity contractures as well. And so you cannot do a standard approach in this case. Mike did something really creative. He put both legs into the right stirrups. He did a cut down PU, and then he did a cystolopathy and HoLEP on this patient. All right, so what are my thoughts in terms of doing large glands in general? Think about a PU, right? Think about it beforehand, especially big glands and big patients, pretty good chance you're gonna need it. And I think if you're thinking about it beforehand and you tell the patient about it beforehand, it's much easier from a psychological standpoint to just do it, because at that point you're not really doing anything different. You're not really, kind of thinking about it as a problem. You really have already pre-thought about it, okay? The second thing is don't rush your procedure. And I think one of the things that we all kind of get into while you're learning the procedure is when you're doing bigger glands, you think, oh, I got to do it faster. I got to do these steps faster. And it's actually not the case. And I've made this mistake before where you're trying to go faster and then you end up with all the problems of having basically bad technique. You got bleeding, you got different planes, you got a perf here and there, and then all of a sudden you have to rush even more, and then you're in real trouble. Okay, so there's a special ops saying that slow is smooth and smooth is fast. 100% true when it comes to HoLEP. There's just no way. You just stay in your planes and it'll get you there soon enough. I tell everybody with these big glands that they could have a 2-stage procedure. I tell them up front, even though I'm not thinking necessarily that they're going to have one. I think it's important that they prepare to have one. That way, if you run into any trouble at all, you can just say, okay, you know what, I've already told him he's going to come back, possibly. Easier to actually just make a safe decision rather than trying to do everything in one shot. Okay, and lastly, PAE. I'm a big fan. I've done one in N of 1. I told John about it. He just did one, and he loves it. And so this is, this patient, this is a 700 gram enucleation, and this is what he looked like at the time of PAE. That's his urine in the recovery room. I've never seen a big gland look that clean. And you too can achieve that too, but just think about it first, right? All right, so I just want to close with some quotes. I love quotes, and some of these are really apropos to like doing challenging cases and just taking on that challenge. I mean, all of you have taken on the challenge of doing HoLEPs, and you just got to keep kind of pushing yourselves a little bit. The difference between a stumbling block and a stepping stone is how high you raise your foot. I love that, right? I think it's really true, because as surgeons, we're going to learn from the hard cases. We're not going to necessarily learn anything from doing things that are easy. And so just embrace that challenge and plan for it, and you'll succeed. Okay. Talk a little bit about planning. Think about what you're going to do beforehand. And this is a quote from Abraham Lincoln. Give me 6 hours to chop down a tree. And I will spend the first foresharpening the axe, right? The importance of preparation and planning. Here's another great one from Thomas Edison. Good fortune is what happens when opportunity meets planning. So true. And so, again, a great quote around planning. And the last one is really my favorite quote around planning of all time. And this is it from Mike Tyson. Everyone has a plan until they get punched in the mouth. All right, so thank you for having me here. I'm happy to answer any questions.
How about TXA?
Oh, TXA, yes. So I don't give that preoperatively, but I tend to use Amicar. So when a patient heads to the recovery room, generally they're clear because, you know, sorry, Joel, you know, I use a bipolar. So, you know, and so, yeah, so they go there and they're pretty clear. But if they start bleeding again, I give them 4 grams of Amicar. You know, you can also use, I think, 250 of TXA. But by the same mechanism, it really seems to clamp down the venous bleeding. And so I use it every now and then, but it's pretty rare. I would probably say the bipolar works really great.
So can you describe how you close the urethrostomy again? Is it single layer skin only, no subdermal closure?
That's right. I use you know, like a 3.0 chromic, John, and I just close the skin. I put in a catheter, I just close the skin, that's it. Okay. Yeah. You know, 1 to 2 weeks is what I would say. You know, if you're taking the catheter out like at 1 week, you might want to consider a urethrogram. Most of the time it's sufficient, but not always. If you leave it closer to 2 weeks, I think it's unnecessary to do a urethrogram. Yeah.
Did you, great presentation.
Oh, thank you.
And you don't have to explain what you do when you're taking on cases like this. You do what you want.
That's good.
Did you repeat imaging on the PAE patient prior to the HoLEP and after the PAE?
I don't actually, and you know, one of the things that I've found is that I actually like the PAE being fairly close to the HoLEP, so I don't expect to see any size change.
So you're doing it primarily just for bleeding?
Yeah, I just do it for bleeding, and I think what it really helps with is that edema that occurs after PAE. This is kind of like this post-embolization edema, and it's just so much fun. I can't tell you how much fun it was to do a gland that big. I mean, because I love the enucleation part, like all you guys, I don't enjoy the morcellation part as much, but to be doing like, you know, a gland that big and have like nothing to deal with other than just like stepping on the laser is amazing. I think if you waited longer, the effect of that PAE is going to change. That gland, that plane may become like more difficult and maybe a little stickier. You can still do it, but yeah.
I ask because Dan Grolnick and Chris Manicus at Wisconsin have got a series about a half dozen patients that they're doing pre-HoLEP PAEs, and they wait 6 weeks.
Oh, okay.
And they see about a 25% reduction in gland volume.
Oh, okay.
And sometimes, you know, the idea is sometimes that'll shift you from having to do a PU to not having to do a PU, depending on how it shrinks. And they're not seeing really much effect on that surgical capsule. And the ones that I do post PAE, it's like they've had nothing done.
Oh, is that right? Yeah.
Even if it's, you know, 6 months or a year later, the plane is really well preserved.
Yeah.
And my approach to PU is almost identical. Anybody whose BMI is over 35 and their gland is over 250, possible PU goes on their consent and they're counseled for it.
Yeah.
Or if that posterior prostatic urethral length, you know, if it's over 11 centimeters, possible PU. And if you get 2 out of the 3, you're gonna get a PU.
Yeah.
We do them pretty routinely for any prostheses, whether it's inflatable or malleable, because we've had a couple really bad pendulous urethral strictures, even using a 26 scope in inflatables.
Yeah.
We do tend to close ours primarily because I don't want to have to explain it to my recon buddies why I didn't call them to be involved. So but it's a great approach for these hypermassive glands.
Yeah, thank you.
Congratulations, beautiful pictures, beautiful. demonstration. These are really scary for for most people, even those of us who do a lot of this. As an alternative, what I've done a number of these times for the really massive prostates is I'll free the apex normally, like I would do a HoLEP, and my colleague will come in with the robot from above.
I see, yeah.
And then you avoid the morcellation altogether. You take the prostate out that way, and then they can close the bladder neck and kind of like make the fossa smaller. Because that's, I was going to ask you. So my question, that's a comment, but my question is continence with these big prostates.
Yeah, so actually it's interesting. I don't see a big difference. I don't see a big difference. All of these guys, like the ones I've done, I don't see them anymore. They're just done. And you know, part of it, I just try to explain it in my mind. Like I would think, like if you're actually trying to go around a bigger gland, maybe it's going to be more stretch to the sphincter. But the other thing is that because I'm coming in at a more direct line, I think I'm not torquing as much. I don't have to push down, right, to actually get to that anterior plane. I'm actually right there. It's a straight shot. So I think like from an anatomic standpoint, it seems to make sense that it's probably less stressful to the sphincter to do it through to do a big gland through the PU. But obviously, you know, as soon as I say that, I'm going to have a you know, a totally incontinent patient somewhere, you know. Yes.
You're not getting the Coney Island sign with these really anterior prostates where like
You get your scope in the bladder and the testicles are anterior to your resectoscope. That's a Chandler Dorism. I can't claim credit for that, but the Coney Island sign.
Yeah.
And Dave, Jess Mandeville and Dave Keynes will do that too, that combined approach, robotic and endoscopic.
Yeah.
And they really like that too, especially for these huge glands. Yeah.
because he'll never see the apex from above, so you get that meticulous dissection.
That's great, yeah.
All right, no more questions? Let's take a one more question.
If you have to stage these, what do you do with the PU in the interim?
Oh, so I just close it normally. Yeah, that's a great question. So what do you do if I have to stage it? So I just close it normally. I don't re-enter through the PU. When I do the morcellation, I just do a standard transurethral approach. And you know, I've done a couple of staged morcellations just because sometimes you run into, you know, really dense adenomas that you just have to wait on, right? But it's interestingly, when I look in to do a stage morcellation, it seems like the adenoma is already in the fossa. I don't have to chase it up there. So I wait like probably at least 4 or 5 days. Yeah, I tend to wait like a little bit longer because I just want it to like soften up, like, you know. So probably about 4 or 5 days at least.
You'll get 30 grams a minute with your morcellator.
Yeah.
Let the patient sous vide their adenoma. And when we do that, like if we stage because of a mechanical failure of the morcellator,
or for bleeding or for what have you, you know, when we have to stage morcellation, it's awesome because like you'll literally do 100 grams in 2 minutes, 3 minutes, and we don't put a catheter back in. You know, if we haven't done a PU, we don't put a catheter back in. They void in the PACU and they go home from the PACU.
Morcellator is also fantastic for those organized clots. If someone comes in, plot.
Oh my God, I'll never use an HoLEP.
No, that's true.
Really
yes.
organized, get out your morcellator. It works really well.
Yeah.
2 minutes total.
All right, we'll have everyone come
All
back
right.
at 3:15.
Thank you.